Hi guys, my name is Allison Nadler, and my group and I are going to talk to you more about Dysarthria. My group includes myself, Rose Owens, Sarah Covell, and Nicolette Freeman. In today's presentation, we are going to discuss the introduction to Dysarthria, different types of dysarthrias, the difficulties and causes, signs and symptoms, and lastly, assessment and treatment options. To start, I'm going to go a little more in depth about what dysarthria is. Dysarthria is an acquired neurogenic speech disorder that is a result from neurological damage to the systems and structures that affect speech production. This disorder is acquired as opposed to developmental and is caused by some specific event. Some common events that can lead to dysarthria are stroke, traumatic brain injury, and disease. There are others as well, but these are the most common. Dysarthria results from notable degrees of one or more abnormalities involving one's speech muscles. This can include weakness, paralysis, incoordination, sensory deprivation, exaggerated reflex patterns, uncontrollable movement activities, and excess or reduced tone. Individuals with dysarthria know what they want to say, but the muscles responsible for getting the words out won't respond correctly due to the specific damage. The medical dictionary definition states that dysarthria is an imperfect articulation in speech. I find this definition very interesting because, as you will learn, this disorder has an effect on all the basic processes of speech. Basically, speech is the muscles in your lips, tongue, vocal cords, and diaphragm working together to help you speak clearly. With dysarthria, the part of your brain that controls them doesn't work well, and it's difficult for you to move those muscles the right way. When speaking, people may not be able to understand this individual very well. Some people with dysarthria have only minor speech problems, while others have a lot of trouble getting their words out. This muscular impairment does affect all the processes of speech, including respiration, phonation, resonance, articulation, and prosody. Overall, articulation errors are the most common feature of dysarthria, followed by the impairments of voice, resonance, and fluency. In regards to the different types of dysarthrias, there are 6 different types. An individual with dysarthria might have an overlap and more than one type of dysarthria may be present. In addition, the type and severity of dysarthrias depend on which area of the nervous system is affected. I am now going to go into more detail about each one, including the site of lesion, the possible causes, and primary speech characteristics. First off, I'm going to discuss ataxic dysarthria. The site of lesion is in the cerebellar system. Its possible causes are congenital condition, CVA, infection, toxic errors, trauma, or tumors. And the primary speech characteristics are imprecise consonants, excess and equal stress, irregular articulatory breakdowns, distorted vowels, harsh voice, loudness control problems, and variable nasality. Next, flaccid dysarthria's site of lesion is in the lower motor neuron. Its possible causes are CVA, congenital conditions, disease, palsies, trauma, tumors, or viral infections. And the primary speech characteristics of this disorder are hypernasality, imprecise consonants, breathiness, monopitch, and nasal emissions. The next 2 types are hyperkinetic and hypokinetic dysarthrias. These dysarthrias both have the same site of lesion, which is in the extrapyramidal system, but they have some different causes and characteristics. For hyperkinetic dysarthria, the possible causes are athetosis, Ballism, chorea, CVA, drug-induced, dyskinesia, dystonia, Gilles-de la-Tourette syndrome, infection, or a tumor. And its primary speech characteristics are imprecise consonants, distorted vowels, harsh voice quality, irregular articulatory breakdown, strained, strangled voice, monopitch, and monoloudness. On the other hand, hypokinetic dysarthria's possible causes are drug-induced and Parkinson's disease, and its primary speech characteristics are monopitch, reduced stress, monoloudness, imprecise consonants, inappropriate silences, short rushes of speech, harsh voice, and breathy voice. Spastic dysarthria is the next dysarthria I will discuss. Its site of lesion is in the upper motor neuron, and its possible causes are congenital conditions, CVA, infection, trauma, or tumors. The speech characteristics for this type are imprecise consonants, monopitch, reduced stress, harsh voice quality, monoloudness, low pitch, slow rate, hypernasality, strange strangled voice, and short phrases. Lastly, we have mixed dysarthria, which is a mix of flaccid and spastic dysarthria. The site of lesion is in the upper and lower motor neuron, and its possible causes are ALS, CVA, or trauma, and its characteristics are imprecise consonants, hypernasality, harsh voice quality, slow rate, monopitch, short phrases, distorted vowels, low pitch, monoloudness, excess and equal strength, and prolonged intervals. Next, Rose is going to discuss a little more about the signs and symptoms.
Hi, I'm Rose. I'm going to go through the signs and symptoms of dysarthria. Signs and symptoms of dysarthria vary depending on the underlying cause and type of dysarthria. Dysarthria can alter speech intelligibility and/or speech naturalness by disrupting one or more of the 5 speech subsystems, which are respiration, phonation, articulation, resonance, and prosody. Allie went over the speech characteristics that are most seen in each of the types. Overall, the most common signs and symptoms of dysarthria are having slurred or mumbled speech that can be hard to understand, having slow speech, the inability to speak louder than a whisper or speaking too loudly, rapid speech that is difficult to understand, voice that can sound nasally, raspy, or strained. Dysarthria can cause uneven or abnormal speech rhythm, which has to do with abnormal stress and intonation. Another symptom is uneven speech volume. It can cause monotone speech, and this is when someone's voice has an unchanging tone. Due to the muscular impairments of dysarthria, people face difficulty moving their tongue and other muscles. You can have a change in your voice. You may sound hoarse or breathy, or you may sound like you have a stuffy nose or are talking out of your nose. Here is an example of one type of dysarthria. It is flaccid dysarthria.
Okay, ma'am.
My baby mother's ring.
Okay, she's repeating, my baby ate a cupcake on the train. Say it one more time.
My baby ate a cupcake on the
Dysarthria may co-occur with other neurogenic language, cognitive, and swallowing disorders. I am going to go over 2 speech disorders and a swallowing disorder that commonly occur with dysarthria. The first is apraxia of speech. This is a neurological disorder that affects the brain pathways involved in planning the sequence of movements involved in producing speech. The brain knows what it wants to say, but cannot properly plan and sequence the required speech sound movements. A swallowing disorder that occurs with dysarthria is dysphagia. Dysphagia is the difficulty to swallow or pain while swallowing. Some people with dysphagia have problems swallowing certain foods or liquids, while others can't swallow at all. Lastly, dysarthria can co-occur with aphasia. Aphasia is an impairment of language due to an area in the brain affecting the production and/or comprehension of speech and the ability to read or write. I interviewed Chris Tjaden, who has a PhD in communication disorders and scientists, and is a professor at UB. She also conducts research at UB in the Motor Speech Disorders Laboratory.
Just so you're aware, I'm not a practicing clinician, so I'm going to talk about it from the standpoint of the type of research that I do and the teaching that I've done in the past, if that's okay. Yep. So I would say in recent years, the vast majority of research that's been published supporting different types of treatment techniques for dysarthria really focus on what I call, and not what I call, but what people in the field call global treatment techniques. So these are treatment techniques targeting functional communication where speakers are trained or cued or instructed to do things like slow their speech rate, increase their vocal intensity, speak more clearly, speak with intent, those types of strategies.
And so what can a communication partner of someone with dysarthria expect? Like, what are the difficulties that they face?
So from the communication partner's perspective, I think there are a number of challenges that they can expect. One, depending on the type of dysarthria and the type of neurological damage, they can perhaps expect reduced speech intelligibility. They can probably expect, even if intelligibility is not reduced, reduced speech naturalness. They can expect, in some instances, changes in the ability to successfully communicate over the course of the day. So it might be things if somebody's fatigued, speech might become worse.
Mm-hmm.
So from kind of the dysarthria perspective, there are a lot of things that the communication partner can expect.
Mm-hmm.
I think as well, just from the psychosocial aspects of dysarthria, people who have dysarthria might be less willing to, let's say, communicate in environments that they may be reluctant or have reduced communication participation. So they may feel less confident or experience problems communicating in real world environments.
Mm-hmm.
So whether that's talking in a noisy restaurant, whether that's talking in large groups of people, so those sorts of things as well.
Okay. And then my second to last question, is it common for people with dysarthria to use assistive devices to help them communicate?
I would say that it's not common, but they are used.
When do you think they're used most?
So my sense is that they're used the most for individuals that have progressive neurological diseases like amyotrophic lateral sclerosis, which is pretty rapidly progressing, and there is a point, depending on the subtype of ALS that you have, that in all likelihood, very quickly, you're going to lose the ability to use speech to communicate functionally. So for those individuals, I would say augmentative communication is probably used the most with that population.
Mm-hmm.
I think it is used in other populations. It's always on the part of the clinician. It's always kind of a negotiation.
Mm-hmm.
The client has to be interested in having that assistive device, needs to be willing to learn how to use it, and then actually use it as well. So they've been used, like I said, ALS, they've been talked about, let's say, in Parkinson's disease and traumatic brain injury sometimes. They could be really sophisticated types of electronic devices, but it could also just be a very simple sort of communication support device that's more tablet-based or even paper and pencil type-based. Analog.
Right. Yeah, that makes sense. All right, that is it.
Great.
Thank you so much.
Oh, you're welcome.
Yeah.
Due to the many causes and severity types of dysarthria, in many cases an individual diagnosed will have difficulties communicating with others due to the fact they have little to no control of the muscles they use when they talk. The most common causes are a result of strokes, traumatic brain injuries, conditions that may paralyze the face or cause weakness, such as Bell palsy, or ALS, otherwise known as Lou Gehrig's disease, degenerative diseases like Huntington's disease and Parkinson's, and lastly, drug and alcohol abuse. We can note that all these common causes are acquired and mostly happen after birth. Due to the fact there are different severity levels of dysarthria, we can conclude that each individual will have different symptoms. We can measure the levels of dysarthria on a mild, moderate to severe scale. Oftentimes, an individual diagnosed with mild dysarthria will have speech errors. However, these speech errors do not affect the individual's intelligibility. We can see this in patients who have been diagnosed with Parkinson's. This meaning they know what they are trying to say, but due to the weak muscles, it results with speech errors. In a moderate level of dysarthria, we can see a reduction in speech intelligibility, often seen in patients diagnosed with cerebral palsy.
And lastly, a patient diagnosed with severe dysarthria can be seen to use alternative communication methods in order to communicate with others. This is most commonly seen with individuals after a stroke. These factors increase the risk of acquiring dysarthria. All these factors can affect the individual in different ways and will also depend on the severity and type of dysarthria that has been acquired. In most cases, dysarthria will affect older individuals rather than younger ones. Oftentimes, individuals diagnosed with dysarthria struggle with communication. Because of this, more times than not, it can lead to the individual to become frustrated and angered. As a result, many patients with dysarthria suffer with social aspects and can even be diagnosed with depression. This is why it is very important for an SLP to help aid these individuals in finding the best communication methods that best suit them. By doing this, it will help limit these complications.
Regarding the assessment of a client with dysarthria, a lot of the times speech-language pathologists are referred them from another professional, like a neurologist, who will determine the etiology of this disorder. So the client may have already undergone other measures of assessment, like brain imaging tests, so CT scans or MRIs, nerve studies, or blood or urine tests. An SLP, when assessing dysarthria, may even work collaboratively with these other professionals to determine the etiology through the way that we're able to determine the type of dysarthria the client has or the severity of it. So we have both informal and formal assessments to go about that, and we begin typically with the oral motor examination or subjective measures like the client and significant other rating their speech intelligibility, and then we will also acquire a speech sample. The formal assessments are typically criterion referenced, and there's a lot available for us to utilize, but the most frequent one used is the first one here, FDA2, the French A dysarthria assessment. So just an example of one, which is the Newcastle dysarthria assessment, basically is a documentation that we're able to use to interpret our findings, and it just gathers some information regarding the lesion, which assists in classifying the dysarthria, and then targets each subset of the speech process. So it starts with a conversational speech assessment, and then observes respiration, which we know is a facet of impairment in clients with dysarthria. And then it goes on to phonation, where results are cross-referenced with typical norms, and then we'll assess their stability with volume, and then any hyper or hyponasality within resonance. And then within the subset of prosody, we'll assess their ability to intonate and stress segments of sentences. And then articulation, in this subset, you can see a lot of comparisons to the oral mech exam, which is performed as well. So that basically just indicates that the prominent and essential components of an assessment for dysarthria are the oral facial examination and speech samples at both the structured levels and in continuous speech. And that'll provide us the basis for identifying the primary speech characteristics and overall determining their intelligibility. To treat a client with dysarthria, the hierarchy of goals first targets respiration and resonation, then phonation, and then prosody. And some of these goals include adjusting their speech rate, strengthening muscles, increasing breath support, improving articulation, and then working with the family members to help communication with the client. In therapy, to target these goals, for adjusting speech rate, we'll encourage them to slow down their rate for intelligibility and to start small, which might include introducing their topic with one word or a short phrase before they go on to speak in a longer utterance. To strengthen their muscles, we'll encourage more movement of their tongue and lips and then safe chewing and swallowing. To increase breath support, we'll do tasks going over taking deep breaths before utterances to improve their loudness, and then to generally keep it short if they're fatigued. To improve articulation, we'll do tasks of syllable repetition, both within words and in sentences. And then to help family members communicate with the client, we'll target the frustration that dysarthria patients are known to have, given that they are receptively comprehensive. And then we might introduce the possible use of alternative augmented communication, which could be as simple as a pen and paper, hand gestures, or altogether introducing another device that they're able to use. And a prominent method within therapy is Lee Silverman voice treatment, which targets the loudness of their voice. Although it's hard to prevent dysarthria due to its many causes, we are able to reduce the risk of stroke, and we can do that by living a healthy lifestyle. So here we have listed some examples of how we are all better able to do that.